My name is Mark Schiffmann. I want to introduce Rolando Herrero, who is our speaker. Where is Rolando? I don't see, oh, there you are. The lights are in my face. Okay, I've known Rolando for 25 years, and I want to say that it's a great honor to introduce him. We chose Rolando for this because he has been important to all the phases of epidemiology and public health related to human papillomavirus. He started in the etiology phase in the 1980s when we were still uncertain about the role of human papillomavirus, and did one of the first studies with a group of people, ending up publishing with Bill Reeves, who passed away this year, in the New England Journal of Medicine, one of the first association studies in a 4-country case control study in Latin America. Seeing the opportunity to go forward with HPV, he then went into the natural history phase that followed with the cohort studies and launched the Guanacaste cohort back in his native Costa Rica, which ended up having both etiologic and natural history proving the role of HPV in preceding and predicting cervical cancer, also invalidating some of the earliest tools. There was a validation of hybrid capture, there was a validation of thin prep, and we did a lot of early work there. Then he moved into the phase of validating prevention tools, both screening tools and also the Costa Rican vaccine trial. Many of his colleagues are here. He did a stint at IARC and did tremendous amount of traveling, doing projects throughout the world. And now he's back at IARC, working on the next phase, which is implementation of screening prevention with Shankar. So he's really been important throughout the history of this meeting and the history of the field. He's also my friend, and I'm very honored to have a talk that's devoted to his vision for Latin America and prevention with HPV-based strategies. Rolando.
Okay. Good morning. Thanks, Mark, for your introduction, and I want to thank the organizers also for inviting us and organizing this meeting in the middle of paradise. And I'm going to discuss a few aspects in relation to perspectives for cervical cancer control in Latin America. So, Latin America is a very vast and multi-ethnic and multicultural region with a population of about 600 million people on a surface of 20 million square kilometers, with a gross national income per capita of $8,000, which is really like a middle income compared to Africa, which is around 1,000 average, and Europe, which is about 40,000. Literacy in women is 91%, unemployment 8% in 2011. Poverty, really real poverty at the international level, which means earning between $0 and $4 per day, is 30% still, but it has come down from 45% in 1995. And it is considered the most unequal region together with sub-Saharan Africa. The life expectancy is of 74 years, but it was 57 only in 1960. Infant mortality is 17, and it was 97 in 1960. And as part of the theme of this talk, we will discuss one of the enormous problems that have to do with cervical cancer and the difficulties for controlling it, which is the enormous inequalities that we have in our continent and in the world in general. And if you can see here, the infant mortality is varies a lot, tenfold within Latin America. It is only 5 in Cuba, and it's 10 in Chile or Costa Rica, Uruguay. But in Haiti or Nicaragua, it's still around 60. There is access to safe water for 96% in urban populations and 71% in rural populations. So cervical cancer is the leading cause of disability or years of life lost in many Latin American countries. And here you can see that the countries in yellow are the ones where cervical cancer is the leading cause of disability, cancer-related disability. And you can see that still many countries in Central America and mainly in the Andes, still in Colombia, Peru, Ecuador, Bolivia, it remains the leading problem in terms of cancer. There is enormous differences in the incidence and mortality between countries, as we know. And for example, the countries with the highest income and or that have the most developed health systems have managed to control cervical cancer to some extent. But not so as I said, in the countries that we showed before, and we have a big difference, almost tenfold difference in incidence and mortality from cervical cancer between countries. Now, cervical cancer is declining in Latin America at a slow rate and has been doing it for several decades probably, with many pockets of very high incidence remaining. That's one of the main problems. And this has been shown in different talks before here, the big difference, regional difference, and whenever you look at these regional differences, of course, the lowest development areas are the ones where the highest incidences are. And I want to point out that this is a very serious problem, especially in the places where there has been a control of cervical cancer. The US is much lower than any of the countries I showed on the previous slide. And however, there are extreme differences within the US. And you can see it for low SES, low socioeconomic levels within the US for black women. The mortality is just like it is in anywhere in Latin America. Well, not in the worst places, but in the places that have arrived at some control. But there is enormous inequality as well, directly related to socioeconomic differences. So part of the reductions in cervical cancer rates are probably related to reductions in fertility rates, and this is the birth rate, for example, in Mexico, that has come down from about 35 to 20 or something. And that's probably part of the explanation, as we know that parity is a risk factor for cervical cancer. At the same time, Mexico has increased their coverage, screening coverage. The scale is not here, but it's about 80% here. And then there is some decline going on. Brazil has shown very slow and trend of decreasing mortality, but it's still pretty high, about 7 per 100,000. And in Costa Rica, we have observed an important decline since the late 90s after the reorganization, and we think partly as the influence of the extensive technology transfer that we've had with the NCI in good measure. And again, in Chile, for example, where the rates are low, this is the trends over time, and Caterina Ferrecchio published this year. And there is a big difference between by level of education. So women with more than 12 years of education have these levels of cervical cancer, very low. But still, among women with 0 to 8, despite the decline, there is still very high rates. So scientific research with extensive participation of Latin America has resulted in new primary and secondary prevention methods. And as Mark mentioned, we started with the Latin American case control study in 4 countries that recruited about 1,500 cases and controls. And it investigated risk factors and HPV biomarkers. It was led by Luis Brinton from the NCI and William Reeves, as Mark said, who passed away recently. Then we went on to the Proyecto Epidemiológico Guanacaste, a very ambitious project of the natural history of HPV and cervical neoplasia. with about 10,000 women that were extensively screened and specimens and follow-up for 7 years and extensive publications on these topics and many other aspects of the disease. And here we have Mark and Ana Cecilia, Conchita. And then the same people in Costa Rica went on to do additional studies. For example, the Costa Rica vaccine trial, as Mark, I think, mentioned, is an independent trial using GSK's vaccine with more than 7,000 women, and it has shown efficacy against cervical, anal, and oral HPV infections. Let me just, and this is, sorry, this was also with Alan Hildesheim and Paula Gonzalez and Amy Kramer. And the TATI project was another very important project and screening intervention in the Amazonian Peru with more than 36,000 women who were screened with low technology approaches. And I mean, the pictures are just random people that I found for whom I could find pictures, because this doesn't mean to be all-inclusive of all the participants. For example, the TATI project had Jose Jerónimo, had Vivian Su, and many others, and of course, the support of the governments. In Colombia, there has been a lot of activity, also with collaboration with Nubia Muñoz. They had the Bogotá cohort, studies of cost-benefit, screening evaluation, and there is also in Antioquia the infection and cancer group that's very active doing research in different aspects, with Raúl and Gloria leading these efforts. There is also the multicentric case control studies in Latin America, led by Javier, Bosch, and Nubia. In Latin America, they were conducted in Colombia, Peru, Brazil, and Paraguay, and they established the HPV as a necessary cause of cervical cancer. They defined the types that are considered oncogenic, allowed the investigation of cofactors, etc. Also, we started some prevalence surveys in different countries around the world, and they were continued by Silvia Franceschi and Gary Clifford when he was a kid, as you can see. So this was part of a worldwide effort that ended up including more than 30 countries, and it was very useful for defining prevalence differences by country. There is enormous activity at the Instituto Nacional de Salud Pública in Mexico, with more than 200,000 subjects participating in studies. They have evaluated screening techniques, self-collection, program evaluation, vaccine trials, and there is the leadership of Eduardo Lascano, Mauricio Hernández, Jorge Salmerón, etc. There is also in Sao Paulo, in Brazil, with Eduardo Franco and Luisa Villa, the Ludwig McGill cohort. Again, a study of screening and natural history of HPV and cervical neoplasia with more than 2,500 women. And there are many others. It's hard to list all the activities and all the research projects that have been going on in collaboration in general with institutions, either in the United States or Europe. So it's been a very, very fruitful collaboration that has provided a lot of technology transfer and probably is going to have enormous impact eventually in the control of this problem. There is, in Honduras, an extensive HPV research group, the Cancer Institute in Peru, the work of PAHO is also very active, the LAMS study, we have in Argentina, Instituto Malbrán, we have Alejandra Picconi, who has the regional reference laboratory for HPV, and also the PATH with Jose Jerónimo has been doing a lot of work in Nicaragua and other areas. So we now think that vaccination of adolescents is going to dramatically reduce cervical cancer incidence and mortality in the next few decades. That's definitely our hope. And of course, we have very effective vaccines. We have almost 100% protection among women who are not previously exposed for both Gardasil and Cervarix. And fortunately, initially we were very concerned because of the extremely high prices. There has been some reduction in price, and that has allowed the revolving fund of PAHO to obtain reasonable prices for some of that can be afforded by some of the Latin American countries. And you can see that vaccination is proceeding and it's starting, and there is already several, Mexico, several big countries, Mexico, Argentina, Colombia, Peru, that are already vaccinating young women in the entire country. There is also interest in finding out if it's possible to simplify the delivery schedules, because maybe we're giving a higher dose than may be necessary, and that implies a very large additional economic and logistical effort. So it is very important to continue to explore these findings that came out of the Costa Rica vaccine trial, that possibly the efficacy of the vaccine with less than 3 doses may be just as good as it is with 3 doses. There is a very large trial in India in young women that is trying to address this with efficacy, with more efficacy data. Now, there is still a lot of issues in relation to HPV vaccination. We still, as I said, we need to continue to explore alternative schedules that can, as I said, simplify and make more affordable these programs. We need to have broader spectrum of vaccines. That's very also essential for eventually being able to stop doing screening, and which means at this time we cannot do completely. We need to continue to reduce the cost of the vaccines and stimulate the development of new vaccines at very low cost. We still don't know how long the protection is going to be or what the impact will be on reduction of cervical cancer. That very soon, I think, we will start seeing data on reduction of cervical cancer. There is the issue of expansion of target groups to males in the context of prevention of infection to women, and of course, separately for prevention of conditions in males. And then also to expanding the vaccination target groups to younger children in order to incorporate into the childhood vaccination programs, which are much more comprehensive and have more coverage in the very poor areas. And also, it's important to define better on the usefulness of catch-up of older women. Of course, there is a lot of issues in relation to ways to increase coverage and reach equality in the delivery of the vaccine. And very importantly also is the sustainability of the programs. I think Nubia mentioned recently, and we've learned that there have been some of the programs in Latin America, unfortunately, have been interrupted for different political or economic reasons. And so it's very, very important when they start that they are sustainable. Now, most women alive will not benefit from vaccination, and so we need screening programs to be established and improved using new technologies. In Latin America, it is a long history of secondary prevention, but one of the key aspects to have impact that has been very limited, the impact so far, is to change the paradigms of the medical community through lobbying and through medical education. If we can convince the governments and the medical communities of the need to follow certain guidelines and to change the paradigms and to change the technologies, that can really happen. That's what we have seen in the places where there have been successful programs. And I think that's key. That's a key element. And for example, in Argentina, where they have started a very large project and where they introduced HPV, it was done through very, very extensive, they conduct meetings with basically all the gynecologists in the country, several meetings a year with everybody, with international speakers to explain the situation and really change the paradigms. Of course, we cannot overemphasize the need to establish organized programs. That's what's definitely being lacking, and it's only where there have been organized programs it can be done in a cost-effective manner. If you do it like in the US, I mean, like very, very frequently in an opportunistic way. It can also be effective, but that is extremely costly and inefficient. Of course, high coverage and population-based programs are essential. The key also is the follow-up of abnormalities. We know that that's where the programs fail, when we don't follow up the lesions detected, and it's totally unacceptable not to detect and not to act on what you find. Of course, there is the need for training, quality control, and this is not just empty words on a list. This is really aspects of the programs that are essential. The teams need to be multidisciplinary. There are many aspects to this. We need information systems and evaluation. And an important thing is the coordination with the immunizations program. That is a recent development, given that now we have a vaccine. And I think they can provide a very important input into the organization of screening programs, because they have the expertise and the teams and the logistics to really reach very high coverage in most countries around the world. So that kind of expertise is probably going to be a big addition to screening programs if they can work in a coordinated manner. Now, it is clear that when considering screening programs, new screening programs, or reorganization of screening programs, we need to reformulate the role of cytology. This is a recent study also from Caterina Ferrecchio, who evaluated the performance of screening with cytology versus hybrid capture. And despite the fact that Chile is the place where cervical cancer has declined, where the laboratories are considered to be some of the best. I mean, it used to be the reference laboratory for most of Latin America in the early 90s. And however, they found that when they included 8,200 women who had hybrid capture and cytology. They all went to colposcopy and got a final diagnosis. And the sensitivity of conventional cytology for CIN3, for CIN2 or more, was 34%. So this is, of course, is in concordance with what has been seen in other areas. We know that it is very limited, and it only through repeated examination is that it achieves its goal of reducing cervical cancer. So it is, we now have the opportunity to do HPV testing, to incorporate in primary screening HPV, which is an objective method. It's highly reproducible and accurate. It has been shown to be effective and even to reduce mortality. As we know, in one-time HPV screening in India showed a reduction of mortality within a few years of about 50%. It has the advantage that with its very high negative predictive value, it allows extension of the screening intervals to every 5 years or even every 10 years. And even in the United States, where there has been a lot of reluctance to change to HPV primary screening, now it has been, I mean, the recent guidelines call for co-testing still with cytology and pap smears, but given the negative predictive value of HPV, they have proposed to extend the interval to every 3 years, which shows how robust the information is on this negative predictive value. The enormous advantage also of HPV testing is that it allows self-collection, and this is something that needs to be explored and to its full extent, because it's very promising, not only to overcome barriers that may be related to the women themselves or geographic barriers, but also limitations of in staff and personnel in the health systems can be also benefit from the use of self-collection. And also HPV is probably going to be the ideal test after when we do screening after vaccination. The disadvantages is that as we know, it has limited specificity. We need to figure out how to follow up the women who are positive but have no disease. There is certain technical requirements, and the quality is not necessarily uniform everywhere. has the problem of social stigma and high cost. So this is one of the proposed new screening algorithms, which is based on primary testing with HPV, followed by cytology. There is this idea, in reality, that cytology will be better, will have a better performance if it's done in a lower volume, lower workload, and also when it's done among positive women, because that will increase the level of awareness of the cytologists, and the positive predictive value will be much higher because of the presence of many more lesions. I think we have talked about this high-quality cytology that I think it remains to be proven that that cytology can really perform well in these circumstances. So in this type of program, women who are positive on cytology will go to colposcopy and evaluation, and the negatives have a repeat HPV testing, different intervals, and here is where the exploration of new biomarkers is underway, and there are a lot of very promising biomarkers for triage of the positives that either don't have an abnormal cytology or who are negative. So in Mexico, for example, they have already incorporated this into their programs, and so they are doing for primary prevention. They are vaccinating girls between 9 and 10 years, and they actually have basically a two-dose schedule, because they have decided to vaccinate at 0, 6, and 60 months. So they are postponing the third dose of the vaccine to 5 years after the first dose, waiting for more data to show that the immunogenicity and possibly the efficacy of 2 doses is sufficient, and maybe the third dose is not necessary. This has been done in schools and the community. And for secondary prevention among sexually active women, when they are under 35 years old, they are doing traditional cervical cytology. But the main focus of the program is on women over 35, and for them they're doing they are applying an algorithm similar to the one I presented before, with HPV testing for primary screening and triage with cytology for the time being. In Argentina, and I think this is the picture of the team in Argentina, led by Silvina Rossi. It's an extraordinary program, because they have, just for the cervical cancer control program, they have a very interesting multidisciplinary team. In fact, Silvina is a social scientist, and she has all kinds of experts in education, gynecology, sociologists, anthropologists, etc. And they have been given enormous resources, basically from the government, to expand the program and to introduce HPV testing through the country. And they have, as I said, they have started with a very extensive educational program for older physicians. And they have already started their pilot project they have started in Jujuy, the province of Jujuy, where they are using HPV testing in about 75,000 women. And it's going very well, and they are also incorporating research components, and there is a lot of excitement in the community there for self-collection also, even in these communities that tend to be indigenous communities. There is a very good participation. And in that sense, self-collection, there is the recent publication by the Mexican group, where they show that they randomized women to undergo HPV testing with self-collection versus pap smears. And they found that in the group with HPV, self-collected HPV, they found 10% positive test versus 0.38. They detected 3 or 4 times more CIN2 or cancer with HPV than self-collected than with pap smears. Of course, this is the benefit of HPV, which is better than cytology, but this has been shown that it is almost similar when you do self-collection compared to clinician-collected specimens for HPV testing. There is, as I said, there is still pending issues with HPV testing. Limited specificity is a problem. Definition of triage methods in low and high-income countries. Reduction in cost, that this is being also discussed with PAHO to follow the model of the revolving fund for purchase of vaccines, to apply a similar model for the purchase of HPV tests for Latin America, and that should be also, of course, for other areas. There are issues in relation to the opportunity of results that we mean it still takes a lot of time, and it has to be transported, taken to laboratories. The results take a lot of time, so we have to have the opportunity to bring the woman back for her follow-up. And, of course, a lot of investigation in relation to psychosocial impact of HPV. Now, there is another important issue to finalize that I want to mention, is that some areas require simplified programs given the low resources or limited access. There are really many all over the world, and that's exactly where the pockets of high risk are, is in the difficult to reach areas. So we need to consider simplified approaches. So we have to reach compromises. So we have to accept a reduced target population and maybe consider doing it in only one age group, maybe only once in a lifetime, basically, but to every woman in a community, but at least once in a lifetime. And that has even been shown to have an important impact in cervical cancer mortality. We have to use simplified tests, and when we use simplified tests, we're going to sacrifice in sensitivity and specificity. So we have to know that we're going to miss some lesions and that we're going to over-treat. But if that's the only thing that's affordable, that has to be realized, and that doesn't have to mean that you cannot intervene in these populations. We have to do treatments that are simple and easy to perform, like, well, cryotherapy. Not that it's easy, but it's less complex. And also to limit the post-treatment follow-up care. One thing that cannot be compromised is the triage and diagnosis of the lesions that are detected. If you go out in a community and you detect lesions, you must treat whatever you find there, or arrive at the diagnosis, and then screen and treat possibilities can be very useful in that context. The coverage has to be high. You're not going to have any impact if you go to a rural village and you do 10% of the population. It may benefit those few women there, but you need to think big to reach the groups that really need it. And there needs to be also evaluation of program impact and quality assurance to make sure you're really doing something. For this, visual inspection techniques can be a starting point that can be done, and this is what's been recommended in many places in Africa, at least to start generating some awareness and some experience in the health providers. It has the advantage of giving immediate results, needs almost no equipment, limited qualifications, simple training, of course, very low cost, and it can provide immediate treatment. It is, as I said, limited sensitivity and specificity, very variable results depending on the type of training, and of course represents possibly substantial over-treatment. So another approach is to do HPV tests, and in this context we learned that CARE HPV is going to be in the market, somehow in the market, because not for Latin America for the time being, because it's going to start in China and in India. So we're probably going to have to wait if we ever have access to CARE HPV. But in any case, HPV test, even if it's not done with this inexpensive way, can be the primary screening method, and there is the possibility of triaging with visual inspection if you don't have the possibility of doing colposcopy, biopsy, etc., or cytology. Of course, we know that this immediately reduces your sensitivity, But it is an approach that can be considered, and of course, the ones that are negative on visual inspection, you have to follow somehow. Now, in extreme cases, you just have to do HPV or just visual inspection, and even consider immediately treating the lesions that you detect with cryotherapy. So this is in places where there is all these limitations that we have discussed that are valuable approaches. And for example, in Colombia, they are doing precisely that. In remote areas, they are doing screen and treat, and they're doing visual inspection. And in the urban areas, they're introducing HPV testing. So in conclusions, I want to say that a new era has begun, I hope, for cervical cancer control in Latin America, but we still need concerted efforts of academia, policymakers, NGOs, advocacy groups, and governments to realize the potential of all these new preventive tools. And also, on behalf of the Latin American families, I want to thank the HPV community for all your efforts. Thank you.